Have you ever had a patient tell you about their bowel habits and you kindly laugh and say, "Oh, wrong end. I'm the speech therapist. I work from the neck up." It's totally okay if you have said something like this because a ton of us have. When it comes to the gastrointestinal arena, our goal is just to help people safely get food to enter the GI system, not exit it, right? Well, just like everything else, it's all connected. I'm going to talk about 3 reasons why MedSLP should regularly include the question, "When was your last bowel movement?" into their assessments. Let's dive in.
I'm Theresa Richard. I've been a medical speech pathologist for 15 years. I'm a board-certified specialist in swallowing and swallowing disorders. I'm the founder and CEO of the MedSLP Collective and MedSLP Education.
Number 1, constipation can contribute to dysphagia symptoms, especially esophageal complaints. If the lower GI tract isn't working well, then the upper part of the GI tract can also be negatively impacted. The best analogy for this is a sink with a clogged drain. You might be able to get water down the drain at first, but if there's a blockage, then the drain can no longer do its job. Swallowing and digestion requires intestinal motility. Some people with constipation might complain of feeling like something is stuck in their throat, or food gets stuck in their throat, which is also known as globus sensation. They might feel full quickly or not want to eat at all, further contributing to malnutrition or dehydration. And of course, the more dehydrated they become, the worse the constipation can become, further contributing to swallowing and GI symptoms, and the cycle perpetuates. One thing MedSLPs in particular should know is that Parkinson's disease is frequently associated with gastrointestinal dysfunction, most commonly constipation. Constipation may even show up as an early symptom of Parkinson's disease. This is because the loss of dopaminergic neurons contribute to constipation. So not only are we looking at the oropharyngeal dysphagia directly caused by Parkinson's disease, but it's important to consider the secondary effects of constipation that Parkinson's disease can also cause. We should also consider that starch and xanthan gum-based thickeners could potentially cause or exacerbate constipation. So keeping this in mind for our patients with constipation or diseases like Parkinson's that could cause constipation is important. Speaking of thickeners, it has been found that starch-thickened liquids will lose their viscosity and turn into thin liquids when mixed with a laxative called PEG, which stands for polyethylene glycol. If you have a patient who is on thickened liquids and they're prescribed this laxative, make sure to check that the laxative does not get mixed into starch-based thickeners. Xanthan gum-based thickeners are a better alternative. An SLP friend of mine once shared with me that she started to notice patients with constipation frequently complaining of a lump in their throat and difficulty with swallowing solids. She would do a VFSS and not find any signs of pharyngeal dysphagia. Sometimes she could catch slowed bolus transit through the cervical esophagus, but nothing that would let her immediately say, "Aha, there's your dysphagia." Cases like those would turn more into symptom management, just focusing on what the patient found comfortable, because nutritional intake would become the concern. Then oftentimes, with her patients who were constipated, they would report improved symptoms once they've had a bowel movement. Anecdotally, she felt like she saw this a lot, almost to the point where she would start to predict these patterns. Because of this, she made it a point to always document bowel habits and symptom complaints. She also would collaborate with PT because increased movement could help with increased bowel movements, which could then help reduce the dysphagia symptoms. Number 2, constipation can contribute to pediatric feeding disorders. Constipation is fairly common among the pediatric population. However, chronic constipation in kids can lead to or worsen feeding difficulties. One study in 2019 looked at the prevalence of constipation on 93 children who were in a 4-week intensive feeding program. They found that 76% of these children suffered from constipation at some point during their feeding program and required the use of a stool softener. To quote the article, "Whenever a child unexpectedly did not do well during a therapy session, the most frequent cause was fecal impaction." SLPs who work with feeding in the pediatric population need to know this information, as children with feeding disorders are at greater risk for failure to thrive, oral texture aversion, sensory integrative difficulty with food selectivity, and nutritional and developmental deficits. Not to mention the impacts feeding disorders can have on family dynamics and social events. While pediatric feeding disorders can have a wide range of etiologies and exacerbating factors, constipation has a surprisingly large impact on diagnosis. In 2016, Melanie Potok, an SLP and pediatric feeding specialist, contributed a blog to the ASHA Leader titled 5 Common Mistakes and Solutions When Dealing with Kids' Chronic Constipation. She points out that kids, particularly picky eaters, need to have regular, almost daily bowel movements, which will allow them to feel hungry and increase their desire to try a variety of foods. The 5 common mistakes she highlights when it comes to managing chronic constipation include adding more fiber, relying too much on laxatives, expecting kids to pay attention to the urge to go, insisting on more fruits and vegetables, and pushing more fruit juice. Her solutions to these common mistakes were much more child-centered and less likely to exacerbate any food aversions the child already may have. If you'd like to read the full blog post, you can find the link below. One Peds MedSLP posted a question inside the MedSLP Collective private discussion group about whether or not PPIs, or drugs that neutralize stomach acid for people with GERD, could cause constipation, particularly for her patients who were on feeding tubes. She was noticing a lot of her chronically constipated Peds patients who were on feeding tubes were also on this drug. Several members and mentors came in with their thoughts and experiences. Interestingly, one side effect of PPIs is diarrhea, so it seemed unlikely that PPIs would directly cause constipation. Others suggested discussing this concern with GI or the RD and ask questions about how often the child receives a water bolus, what the tube feeding schedule is, the caloric density of the formula, and whether or not smaller feeds more frequently or larger feeds more spaced out could be considered to allow for stomach emptying. The overall thought was that it wasn't the PPI causing the constipation. It was the underlying motility issue on top of the fact that people who are G-tube fed aren't breaking foods down in their mouth, allowing salivary enzymes to aid in breakdown and digestion. So many factors to consider with our patients and GI function and how it's all truly connected. I'll be posting other videos just like this one that you won't want to miss, so make sure to hit that like and subscribe button and turn on the notification bell. Do you have any specific questions about constipation and swallowing? Leave a comment below and tell me about it. We'll be sure to get your questions answered as soon as possible. Make sure to stick around to the end to claim a freebie or 2. Number 3. Constipation and GERD co-occur often. As a MedSLP, you might be pretty familiar with gastroesophageal reflux disease, or GERD. It's becoming more common for SLPs to help patients reduce the incidence of their reflux, which can be aspirated and cause aspiration pneumonitis, or even cause vocal fold damage or inflammation. It might not be all that surprising for you to find out that GERD and constipation often go hand in hand. It's all related to motility. If we're offering patients tips on GERD management, it makes sense to take the whole digestive system into consideration. Research has found a whole lot of overlap between GERD and irritable bowel syndrome, both of which are common GI disorders, although they affect different regions of the digestive tract. Like so many of us, I first started out as an SLP thinking I only had to know what was happening from the neck up. And hopefully this information helps you better understand how we truly need to have a better understanding of the entire system. SLPs are starting to work more with GERD and esophageal dysphagia, but don't forget to at least ask your patients about the remainder of their digestive system and when their last bowel movement was. This part of the patient interview process for me was key when it came to getting the full picture, improving my referral process, and providing better education and strategies for patients who were experiencing dysphagia symptoms related to GI function. I've got a free gift for you over at MedSLPcollective.com. You'll get instant access to our free MedSLP Collective clipboard kit. We have a robust and vibrant community of SLPs and mentors to help you out with your toughest clinical cases. Head over to MedSLPcollective.com now to get your hands on this. The link will be in the description below.